The views expressed in this podcast do not reflect those of our training institutions or the APA. The information discussed is intended for educational purposes only and should not be used for diagnosis or treatment. Enjoy. Hello, everyone, and welcome to the American Journal of Psychiatry Residence Journal podcast. Priya here, and today I have the pleasure of speaking with Dr. Margo Funk about a very high-yield topic for trainees, psychotropic medications and QTc prolongation. Dr. Funk is Program Director of the Harvard South Shore Psychiatry Residency Program in Brockton, Massachusetts, and first author on the APA Official Action Statement on QTc Prolongation and Psychotropic Medications, published in the AJP in March of this year. I've also gotten to work with Dr. Funk as my outpatient supervisor over this past year, which has been really wonderful. Dr. Funk, before we get into our discussion, can you tell our listeners a little bit about your path to psychiatry and how you became interested in this topic?
Hi, Priya. Yes, of course. And thank you so much for hosting me on this wonderful podcast. So I actually was not an early interester in psychiatry. I thought I would be an OBGYN. And then in my last rotation of medical school, I did psychiatry and really fell in love with it. So I made my switch into this great field at that time. I did my residency training at Duke University, where we had a really fantastic med psych program and CL psychiatry service. And so that's where I got interested in the topic of, CL psychiatry, but then also cardiac psychiatry, and then kind of continued along that path for the next 5 years when I was an attending psychiatrist at the Cleveland Clinic, which is widely known for its heart and vascular services. So QTc prolongation became something that was important to me and on my radar at that point.
Yeah, it's always fun, I think, for trainees to hear how attendings got to where they are and, what things they've done along the way. So thank you. So yeah, to get us started, let's talk about why we even use the QTc interval in the first place. So I remember when I first learned about this, everyone, on call emphasized the number 500 milliseconds. What is so special about the QTc and why that number in particular?
Yeah, this is a great question. So the QTc is actually one of the major drug safety benchmarks that's used by the FDA and other international regulatory agencies. And it's something that's looked at when a drug is first coming onto the market. The reason why we're concerned with QTc is that it happens to be the most widely used marker of risk for a potentially fatal cardiac arrhythmia called Torsades de Pointes, which is basically a polymorphic ventricular tachycardia that when you look at it on a rhythm strip or on a 12-lead EKG has this characteristic twisting of the points around the isoelectric baseline, and hence the name Torsades de Pointes, which literally means twisting of the points. So it's really important to recognize that QTc is not an absolute risk for torsades, but because it's the most widely accepted marker, it's what we typically use in clinical practice. You do not have to have a prolonged QTc to have torsades, and you may have a prolonged QTc and not have risk for torsades at all. So it's important to understand that point. Now, getting to this question about 500 milliseconds. So we know that the upper limits of normal for QTc in men is about 450 milliseconds, and in women is about 470. But we tend to use 500 in clinical practice because this is the number above which most cases of torsades have actually been known to occur. So your risk below 500 is actually quite low. It's also a really easy number to remember. The other important piece here is that we do not want to prevent patients from being on medications that are really going to be helpful for them and to prevent them from having any sort of psychiatric decompensation or problem because of, a number that may be in the 480s, 490s, without a lot of other clinical substance to say this is a high-risk patient. So, I think the other thing here is that this 500 millisecond number is not an absolute cutoff. So you really need to carefully weigh what are the risks for the patient and what are the benefits of being on this psychotropic medication that may confer some risk. If you have, let's say, a patient with long history of schizophrenia who's been on multiple antipsychotics and is really at risk of true decompensation if they come off of one of those drugs, and then they happen to creep past 500 milliseconds, but let's say in the absence of any other risk factors, we would probably err on the side of continuing to give those medications because we do not want that risk of decompensation. So you really have to weigh the risks and the benefits and look at the individual patient.
All right. So let's say we have an EKG strip in front of us. How is the QTc calculated? And, I think a lot of us have heard about Bizet's versus Friedrich's versus Hodge's versus Framingham's equations to correct the QT interval. Can you tell us why we might use one of these over another?
Yeah, absolutely. So let's kind of start with the basics. So we know that the QTc is the QT interval on the 12-lead EKG that's corrected for heart rate. So when we're actually in practice doing this, and I encourage all psychiatrists and certainly all psychiatry trainees to get into the practice of looking at your own EKGs and measuring these intervals and calculating the QTc yourself, because the more you get into that practice, the easier it will become. And honestly, you'll feel more comfortable making these risk-benefit adjustments and assessments when you feel comfortable with the EKG itself. So we start with, let's say you've got the 12-lead EKG in front of you. You're going to look first at leads V2 or V3, or you're going to find the lead where the cycle length or kind of the heartbeat itself, the individual beat, is very clear, and you can easily find the end of the T wave. So what you're going to do is you're going to start from the beginning of the QRS complex, and you're going to measure the interval to the end of the T wave. So this is where it's important to remember that each of your small boxes on the EKG are 40 milliseconds in length, and then each large box is 200 milliseconds in length. When you're measuring the QT interval, it can sometimes be tricky to determine exactly where your T wave ends. And so when that gets tricky, when it's not cut and dry, a really nice method to use is something called the tangent method. And with the tangent method, you're basically going to trace the tangent of the steepest downward slope of the T wave, and then you're going to find where that intersects with the isoelectric baseline of your EKG. And so that's a nice way to do it that's, standardized, it's widely accepted if it's difficult to find where your T wave ends. Now, a caveat to this is that if you have a T wave that is kind of prolonged and even slurred out, which is typical for what you might see when you end up with a prolonged QT and you have kind of this underlying milieu of multiple risk factors, a common one being hypokalemia. So if you have a long kind of slurred out T wave, it's best actually in that case not to use the tangent method because you can actually cut it off too quickly. And you want to make sure that you're accounting for all of that risk. So in those cases, it's best just to follow the T wave out to the end of the slur. So Priya, then going on to kind of what you do next. So once you've measured the QT interval, then depending on what formula you're going to use, you either want to know the heart rate or you want to know the length of the RR interval. And the RR interval, if you'll recall, is the interval between the R wave in the current cycle length that you're looking at, and the R wave preceding it. So you always want to look at the RR interval that precedes the QRS complex and T wave that you're looking at.
Why is it important that it's the one preceding it?
Because really this is looking at the entire cycle of depolarization and repolarization. And so you want to kind of keep that all together. Also, it's also important in cases of AFib where you might be looking at multiple cycle lengths within one EKG, and it's best to keep those RRs and QRS and T waves all together. So you asked about the formulas, and this is a really good question. So the biggest standout here is that the Bazette formula, which is honestly the most widely used formula in clinical practice. It's the formula that's used in QTc research. This is the formula that's used by FDA. And this is the formula that is typically the default setting for most EKG machines. This is actually the worst formula that we have.
Oh, okay. Well, good to know.
Yes. So the reason is that at higher heart rates, and we consider 60 to be kind of normal, at higher heart rates, Bazette is going to overestimate your QTc. And at lower heart rates, below 60, it's going to underestimate. And when you compare this to all of the other formulas, you really do see that it widely varies as you get further and further away from 60 on both ends.
So if I'm using Bazette's and my heart rate is 80 and the QTc is 500, it's actually probably a little bit lower than that.
Yes, that's exactly right.
Okay.
So there are a number of other alternatives that you can use. And I think for the most part, as long as you're not using Bazette, you're pretty good. There are a couple of situations where you might want to use one over the other. And an AFib comes to mind here. The Friedreichia formula is actually recommended for use in AFib. And Friedreichia is, the actual formula is QTc is equal to the QT interval in milliseconds over the cubed root of your RR interval in seconds. And that's just a funny little thing to remember, that when you're using Friedreichia, RR is always in seconds when everything else is in milliseconds.
Okay.
Same thing for Bazette. Bazette notably is similar to Friedreichia. It's QT interval over the square root of the RR, QT being in milliseconds, RR being in seconds. So Friedreichia is great in AFib. I also like Friedreichia because it's fairly easy just to plug into my phone. Most phones, if you go into calculator view and you turn your phone horizontally, you can do a cubed root. It's pretty easy. But there are a couple of others that are great. And these are more linear formulas. So the Framingham formula, your QTc is equal to QT plus 0.154 times 1000 minus RR. And that's a great one to use. And it's easy to remember. So people often use that one. And then Hodges is another great one. It's QTc is equal to the QT interval plus 1.75 times your heart rate minus 60. And so this is one where you would need to know heart rate. A lot to choose from.
Yes, definitely. So basically everyone should take a look at their EKG on their patient next time they're on call and try out some of these formulas.
Yes. And, it's actually really fun to, you try out all the formulas on the same EKG and see which ones tend to diverge. Typically, it's Bazette that you'll see diverging.
Do you know why Bazette's is used so frequently if it's kind of the worst?
Yeah. So that's a great question. I think it's mostly historical at this point, and because so much research has been done using Bazette. But actually, if you look in more recent cardiology literature, there is a trend towards shifting away from Bizet. And I think more and more people are recognizing that it's just not the best one. So I imagine, in 10 years' time, perhaps research will start looking at different formulas as well.
Sure. Okay. So that was really helpful. Thank you for going over all of that. I wanted to spend a little time asking about specific psychotropic meds. And, I know that a lot of medications, not just antipsychotics, which I think typically think of as being associated with QTc prolongation, there are actually many that are associated with prolonged QTc. And for example, as you include in the APA practice statement, methadone is strongly associated with QTc prolongation and Torsades. So what other meds should we be most worried about? And kind of along those lines, does the route of administration matter? And then maybe you could comment on some other risk factors. For example, combinations of medications, I would imagine, increase the risk, comorbidities of the patient, things like that.
Yeah, this is a great question, Priya. So I think it's actually important to start out with other risk factors, because what we know is that most episodes of Torsades don't occur with just one risk factor. So if you're on one single psychotropic that may confer some risk, and otherwise you're healthy, you have no other risk factors, the likelihood that you would have an episode of Torsades is extremely rare. And so we know that the more risk factors you have, the more likely it is that you might have this fatal arrhythmia. So some of the really important ones to think about, first are bradycardia. So when a patient is bradycardic, you actually have an increased likelihood that Torsades can occur. And the way that I think about this is, if you imagine, on your EKG, you're going beat by beat. And when you're bradycardic, there's a lot of space in between beats. And in that space, then, there's a lot of room to have a re-entrant rhythm take place. And that's where Torsades can initiate. When you're tachycardic, you're just tacking along, and there's not a lot of room for a re-entrant rhythm to happen. And so I actually feel much safer when I have a patient who's tachycardic, because I just know that the setup for Torsades is not as likely.
Yeah.
So bradycardia is really important.
I like thinking about it that way, like having the room to have the event, literally. That makes a lot of sense.
Yeah. So other really important risk factors, certainly if you have a personal history of, any cardiac disease, or if you've ever had an episode where you've had sudden syncope or something that looked like seizures that was never found to be a seizure, or you have a family history of sudden cardiac death, these are all important. Certainly, if you have a personal history of having QTc prolongation that was drug-induced in the past, that's important. Other things that are important would be hepatic impairment, renal impairment. Something that comes to mind is, for patients who have, end-stage renal disease and might be on hemodialysis, there are a lot of really rapid fluctuations of electrolytes every time you have a hemodialysis session. And so that can set you up for an episode of Torsades. It can actually happen fairly commonly. Mm-hmm. So that's one to know about. And then electrolytes, really important. So hypokalemia, hypomagnesemia, hypocalcemia, these are all potential risk factors as well. And, you might think about when we're learning about EKGs in medical school, the U wave, right? So the U wave is something that typically happens at the end of your T wave, and that's from hypokalemia. And so many people then think, and I think this is a correct assumption, and we could ask our cardiology colleagues as well, but that when you have that U wave that's superimposed on the end of your T wave, and you get this prolonged, slurred out T wave, that's your risk right there of torsades. We know that hypokalemia is a risk factor, and we're seeing it happen right on the EKG. Other things to keep in mind in terms of risk factors, certainly in overdose, we see a higher likelihood of torsades if you have a drug that's maybe smaller risk, but then you have someone who overdoses, your risk can increase there. So those are the big kind of setup risk factors to be thinking about when you're prescribing a medication that has risk.
Yeah, and that makes sense, why we recommend when we're, on consult, for example, recommending an antipsychotic. We ask the team to monitor the potassium, magnesium, make sure they're over like 4 and 2, for example. So that gives a little more meaning.
Yes, yeah, exactly. So the other question you asked was about other medications. And it's really important to remember that non-psychotropics can also confer risk for torsades. And the big ones that we typically see would be your antiarrhythmics. Some antiarrhythmics are actually so dangerous from a torsade standpoint that in order to initiate them, a patient would actually be brought into the hospital for QTc monitoring while they're being initiated on the drug.
Oh, wow.
So dofetilide is a great example of this. And there are a few others. So definitely if you're on one of those antiarrhythmics, you certainly want to be careful. Other drugs include your macrolide antibiotics, your antifungals, antiemetics, antivirals. And when we start thinking about antivirals, this also brings up the point of always be aware of your medication interactions, because certainly one drug may affect the metabolism of another drug, and it may give you a setup for increased risk. So always a good idea to use your drug interaction checker. Never feel bad to use your checker because we can't all memorize everything. So you all have permission to please get onto the computer and make a check if you don't remember.
Well, thank you for giving us the permission to not always know everything and to look it up. I think that's a really important thing to keep in mind, especially for the trainees.
And Priya, actually, you mentioned one other thing that I forgot to mention, which was the route of administration.
Right.
So in general, and there's not really great data on this, but in general, parenteral administration would be considered to have more risk. And this is presumably because you would have more drug load getting to the heart in a shorter duration.
I see. Okay. All right. So now that we have all this helpful information and we feel pretty confident in our ability to have a good risk-benefit discussion with the patient, what would you say in terms of how we monitor patients who are on QTc prolonging medications? And kind of along those lines, when should we consider asking cardiology to be involved?
Yeah. So this is a great question. The first point that's really important here is that the absence of a cardiologist, or even the absence of another physician to do a cardiology overread, which basically means the official interpretation of an EKG. If you don't have one of those people, it doesn't mean that you can't order the EKG, because you as a psychiatrist are a physician too, and are just as skilled in reading EKGs as anyone else, and you have a lot of patients who may require this. And so it's totally appropriate for you to obtain an EKG to look at the QTc interval. And if you have other concerns, you can certainly bring those up to a colleague, but don't let the absence of that colleague stop you from getting the EKG in the first place. So that's my first kind of soapbox point on this. Okay. So, but So then, thinking about what to do actually in clinical practice, I think it certainly depends on what kind of psychotropic you're prescribing. So, thinking about SSRIs, in general, these are considered safe medications. Certainly there was some controversy about citalopram, which came up, first in 2011 when the FDA put out a black box warning on citalopram saying it should not be prescribed at doses above 40. And it also said that it should not be used at doses greater than 20 in anyone with liver dysfunction or who is greater than age 60. And then that was, fairly quickly revised in March of 2012 to saying citalopram is not recommended at doses greater than 40, that it should be discontinued in anyone with a QTc greater than 500. And the FDA also said then that doses of 60 were no more efficacious than doses of 40. We could probably agree to disagree on that point. But the important thing about the studies that all of this citalopram controversy was based on is that when you actually looked at the EKG, the increase of QTc when you had a dose of 20 was only 8.5 milliseconds. And at 60, it was 18.5 milliseconds. So if we go back to thinking about our tiny box that's 40 milliseconds in length, you can't really even discern, much less than 40 milliseconds on the EKG. So, it just goes to show that this was not a large increase at all. It would probably not be discernible by the naked eye for any of us when we're, looking at an EKG. And it was based on a single study with not many patients. So kind of where we are now with citalopram is you can be more cautious when prescribing citalopram. This may be the SSRI where if you have a patient with a lot of other risk factors, it would be worth checking an EKG before you start citalopram, or it would be worth considering something else. And sertraline is actually the most widely studied SSRI in cardiac patients and is considered quite safe. So if one of your risk factors was cardiac, I would go with sertraline. I wouldn't go with citalopram. But just know that, the risk with citalopram, though it's higher than the other SSRIs, is not much higher and should not stop you from using that medication.
I'm glad you commented on the citalopram, actually, because I think that's something we commonly hear about, but we don't know all the details about that study, and actually looking at the number of milliseconds it increased the QTc by puts it into perspective, absolutely. And the sertraline, you're kind of referring to the SAD heart trial? Is that what I'm...
Yes.
Okay.
Yeah.
Gotcha.
Yeah, you're exactly right.
Great.
So thinking more about monitoring, so we talked about what to do in the case of citalopram or other SSRIs. I think if you're starting an antipsychotic, it is appropriate to get an EKG at baseline if you can. If you can't, but you have an older EKG, we typically consider an older EKG to be fairly accurate if it was done within 1 month of when you're seeing the patient. So if it's from a year ago, it would be worth getting a new one if you can. But if it's from a month ago, you're probably okay, and you could use that data. So then moving on, Priya, to kind of when would you want to consult a cardiologist? So certainly if there are no other risk factors that a patient has, you don't need to consult a cardiologist at all. You can use your best judgment as a psychiatrist with knowledge about QTc to make these decisions. If you have a patient who has known heart disease and they have an existing cardiologist and you're going to prescribe a medication that may have some risk, let's say an antipsychotic, then it would be absolutely appropriate to consult with that existing cardiologist. But I would say it would not be necessary to obtain a cardiology consult from a new cardiologist in that setting.
Okay.
Okay, so that's if you have known heart disease. If you have a patient who you want to start a psychotropic with some risk and they're on other high-risk medications, their QTc is above 500, or in cases where you've started the drug and you get another EKG and they have a sudden increase of their QTc more than 60 milliseconds, then it would be appropriate to refer them to a cardiologist and initiate a new consultation.
Okay, so even if the QTc isn't above 500, if that bump is about 60 milliseconds or more, it would probably be a good idea to get a cardiologist involved at that point.
Yes, yeah, that's exactly right.
Great.
And then finally, when you would need immediate cardiology, and this would mean like immediately go to the hospital or call 911, is if you have cardiac symptoms. So if you have a patient that is calling you and saying, after they've initiated this drug, now I'm having sudden dizziness, or I had a syncopal episode, or I've been feeling faint, or my family told me I had this thing that looked like a seizure, then it would be important to have more immediate consultation.
Absolutely. That makes a lot of sense. All right. Well, Dr. Funk, thank you so much for sharing all that information with us. I think it's at least really empowered me to feel more comfortable using these medications and knowing how to use them safely and what type of monitoring is appropriate. Is there any last piece of information you'd like to share with us before we end for today?
Yeah, and thank you, Priya, so much for inviting me to talk with you today. I think the most important final take home is that the more you practice with EKGs, the more comfortable you're going to feel. And sometimes this comfort makes the difference between being able to safely say, it's okay for this patient to be on this psychotropic or not. And because you may have colleagues around you they see a number, but they're not considering the clinical context. And they say, we must stop the psychotropic, but you know that this patient may really significantly decompensate because of that. Mm-hmm. So knowledge is power here, and practice with EKGs is going to give you that power and confidence to be able to really be the expert, if you will. You are kind of the psychiatrist expert on these drugs, and it's important to know how that interplays with the EKG. So practice as much as you can.
I love that. That's very valuable information. And growing up, my dad always said knowledge is power. So you're really just reiterating that point that he taught me all along. Thank you.
Good. Yes, of course.
All right. Well, that brings us to the end of today. Thanks again, Dr. Funk, and we will see you again soon.